Hello, let's understand how to interpret antimicrobial testings in the area of multi-drug resistant organisms. What is in vitro susceptibility testing? Susceptibility testing measures the level at which a particular antimicrobial inhibits the growth of specific microbial strain. A variety of laboratory methods can be used to measure the in vitro susceptibility of microbial pathogens to antimicrobial agents. Methods should be standardized based on international standards such as UCAST, CLSI, and ISO. Sensitivity is a widely used term and is essentially synonymous with susceptibility in the context of susceptibility testing. When should a susceptibility test be performed? Susceptibility testing should not be routinely performed on organisms that are part of the normal bacterial flora and usually not considered pathogenic. For example, a commensal bacterium called Streptococcus epidermidis is occasionally isolated from sterile site cultures such as blood, joint fluids, CSF due to inadequate decontamination of the skin during specimen collection. In such cases, sensitive testing should be avoided. How the same staph epidermis can cause a true bloodstream infection in immunosuppressed compromised patients, or in infection at a specific body site such as prostatic joints or CSF, in which case susceptibility testing should be performed. Establish the need for susceptibility testing requires a close working relationship between microbiologists and clinicians. Can the susceptibility or the resistance of bacteria to an antibiotic be predicted? Yes, naturally there are some organisms with natural resistance. Permanent characteristics of the species, which is known and predictable. For example, natural resistance to Klebsiella pneumonia, to aminopenicillin such as amoxicillin and ampicillin, due to beta-lactamase. Natural resistance with Proteus mirabilis, to tetracyclines and colistins. Then we have acquired resistance, which are characteristics of some bacterial strains, which is evolutionary, unpredictable, and justifies the need for susceptibility testing. Then what is the relevance of susceptibility testing in managing the infections? Susceptibility testing helps us to detect a possible drug resistance in common pathogens, susceptible to common antimicrobial agents for particular infections. Most common clinical significant infections observed in ICU are catheter-related bloodstream infections, ventricular pneumonia, tetracycline infection. Sample collection, storage, and transport is very critical step in sensitive testing. We have blood samples and CSF samples as very precious samples. Let us understand the collection, storage, and transport criteria or recommendation or guidelines for the samples. Blood should be ideally collected from both the hands, a pair of aerobic and anaerobic bottles from one hand and pair of anaerobic and anaerobic bottle from another hand. Remember one thing, that most of organisms are facultative anaerobes. Not all are strictly aerobes or not like strictly anaerobic. And anaerobic bottle should be added to an anaerobic bottle for blood collection set. The blood culture bottle should not be refrigerated. It should be kept at room temperature. And it should be immediately transported to the microbiology laboratory within 2 hours of collection. And even in the microbiology laboratory, it should be processed within 2 hours of collection. While the CSF samples needs to be processed within 1 hour of collection, and it should be immediately transported in a fluid bottle to the microbiology laboratory, or in the enrichment medium to the laboratory. Do not refrigerate the CSF sample like blood sample, and if it fastidious organisms like Neisseria or Neisseria meningitis is suspected, then inoculate into pre-warmed plates of chocolate agars, and then incubate it in a 5% carbon atmosphere. This will increase the sensitivity or yield of the pathogen. That was some of the guidelines for processing samples like samples like blood and CSF. Transport all the specimen to the laboratory as soon as possible. The specimen must reach to the laboratory within 2 to 4 hours of collection, and that too they should be transported in a leak-proof containers and sealed plastic bags. If specimen cannot be transported immediately to the microbiology laboratory, then refrigerate it at 4 degrees Celsius or 2 to 4 to 8 degrees Celsius, except for blood and CSF, which needs to be kept at room temperature. What are the timelines for reporting? Standard inoculation preparation takes about incubation of time of 18 to 24 hours. Broad macrodilutions for MIC must occur within 15 minutes after making the standard inoculum. Then after making the inoculum, then inoculation and incubation should occur and should be incubated for 18 to 24 hours. Then reading the results takes place about 24 hours of incubation then, wherein the zone of inhibition or the MIC values from the broad dilution are noted, and the values are then interpreted based on serious and UCAS guidelines. We have automated methods like Phoenix and Whitech, which are based on the principle of broad dilution, and they have automated readings of MIC panels. Then we have also semi-automated systems which consist of both manual and automated methods like panel inoculations and reading and manual incubation of panels. We have manual panels like e-test or e-strips inoculated and incubated manually and read visually by lab personnel then after incubations. The advantages of antimicrobial methods graded methods like e-test is that it has a flexibility by being able to test the drugs the lab chooses. This method is best suited for situation in which an MIC is needed for one or two drugs. E-test results have correlated well with the MICs generated by broad dilutions. However, there are some systematic biases towards higher or lower MICs by e-test. This diffusion is again simple, practical. Results can be easily interpreted by clinicians, and this is least costly. But however, the results are qualitative. Accurate MIC cannot be generated or determined. So what are the advantages and disadvantages of automated systems? Advantage is that the use of instrumentation can standardize the readings of endpoints. There is better data management, produces successive results in a shorter period. A disadvantage is that it is expensive, it requires space for instruments and unable to detect some resistance mechanism. So these are the few images of the automatic. While manual sensory testing takes about 30 minutes for sample collection and transport, for 24 to 48 hours for inoculation and incubation, and again 24 hours for the report generation, and it takes about 2 to 3 days for the therapeutic decision then. While the test time is shortened to nearly 1 day, or less than it, if it is done by automated methods. So any delay in the automated treatment will worsen the prognosis. Hence, automated methods should be practiced as feasible. With the use of automated methods, one can get the report on the same working day. That can help the clinicians to start early. Optimal interpretation of MICs requires knowledge of the pharmacokinetics and pharmacodynamics. Common terminologies used are susceptible, intermediate, resistant. Susceptible means the organism will respond to the normal dosage of the antibiotic. Resistance means it won't respond to the normal dosage of the accommodative. While intermediate will mean that higher doses will be required for the efficacy. We have other terms called as susceptible dose dependent, which it is like a term similar to intermediate, but it is proven by experimental studies and strong studies wherein higher doses will result into effective treatment. Then we have breakpoints. Breakpoints help in the categorization of the MICs, which are the minimum concentration of the antibiotics to inhibit the growth of bacteria. So breakpoints help in categorization of the MICs as either as sensitive, intermediate, resistant, based on guidelines like of CLSI, FDA, and UCAST. The judicious use of antibodies tested the interpretation of susceptibility can help with resistance detection in vitro. For example, strains of Staphylococcus aureus that test resistant to methicillin or oxacillin may test susceptible in vitro to other beta-lactams, especially cephalosporins. However, in vivo data have demonstrated a high level of treatment failures of MRSA infections with beta-lactam therapy. Therefore, the interpretation is changed to resistance for all the beta-lactams regardless of the actual MIC values. So that's the thing, that the interpretation should be based on pharmacokinetics and pharmacodynamics. The selection of the antimicrobial to be tested must be carefully determined depending on the microbial organism and the natural resistance, local epidemiology, and the acquired resistance, the site of infection, and local therapeutic options. The choice of antibodies to be tested is made in relation to their therapeutic value and their usefulness. Regarding this diffusion method, here a bacterial the sample is inoculated onto the culture plate. After an overnight incubation, when the colony we get a colony, it is subcultured into a sensitive plate, and over it the antibiotic discs are then are placed on. After an overnight incubation, the zone of clearing on the antibiotic disc is interpreted to determine the antibiotic as sensitive, intermediate, resistant. Also, we have broad dilution methods and this diffusion method, wherein the MIC obtained or the zone of clearing obtained can be used to categorize this antibiotic either as sensitive, SDD, intermediate, or resistant. For example, if the MIC of a cefazolin obtained by automated method or broad dilution method, if it is less than 1, which wherein the breakpoint is 2, it is interpreted as sensitive. If it is more than 16, and with the resistant breakpoint is 8, it will be interpreted as resistant. So depending on the breakpoint, the MICs are interpreted as sensitive, intermediate, resistant. Hence, the clinicians should be supplemented with in the microbiology reports with the breakpoints so as to guide them with the interpretation of the MICs. What is antibiotic equivalence then? It is possible to test a restricted number of antibiotics without limiting the therapeutic possibilities. Example, equivalence between erythromycin which is tested and other macrolides like erythromycin and azithromycin which are not tested. So we can extrapolate the result of erythromycin to azithromycin on the basis of principle of antibiotic equivalence. Then that is about the phenotypic methods. Let us learn about genotypic methods. Genotypic methods are effective direct methods that eliminate the tedious bacterial culture, inoculation, incubation, and there is no chances of contamination in genotypic methods as compared to phenotypic methods. PCR, DNA microarray, and DNA chips and LAMP are some of the genotypic methods used. LAMP, that is loop method, as thermal amplification. The rapid detection of the resistance genes within few hours helps in decision making for selection of the antibiotic. For example, a patient admitted to a nursing home with symptoms of blood mucus, shivering, chest pain, shortness of breath, and this sensitive testing yields scription and exceptional pneumonia with all the antibiotics, colistin and ceftriaxone ivermectin. Now the patient is now colistin because of the issues related to colistin so that it doesn't penetrate in lung parenchyma, nephrotoxicity, vascular toxicity, and other such factors related to colistin. And the patient is is treated. This is how it's necessary to understand the pharmacons and pharmacodynamics while we choose the antibiotic from the microbiology. So let's say we would response for colistin and against antibacterial cells, pseudomonas, and antimicrobial species. So such updates needs to be borne in mind while interpreting the microbiology reports, which will help the clinician to choose the appropriate antimicrobial. About ceftriaxone ivermectin is a potent beta-lactamase inhibitor with inhibitor activity against class A, C, and some class D beta-lactamases. When in combination with ceftriaxone, the activity of ceftriaxone is restored against gram-negative organisms producing carbaphenemases. So taking these issues into consideration, so the patient was started onto ceftriaxone ivermectin therapy. Antimicrobials, why do they sometimes fail? That's because of the development of resistance. Antimicrobial susceptibility testings and the interference between the clinical diagnosis and the therapy is a key element essential for guiding both microbiology documented and empirical antibiotic therapy. Not only the susceptibility testing result of intermediate interest for the clinicians to guide the selection of antibiotic therapy, but it also plays a key role in the epidemic surveillance tool for both local bacterial and fungal resistance patterns. The evolution of resistance as well as the development of the antibiotics and microbiology techniques make a close working relationship between microbiologists and the clinicians more necessary now than ever before. That's all from this session. Thanks a lot.